It all depends on my schedule, whether I'm going to be able to be here Friday afternoon or not. Do have some running around to do, and I don't know if I'll let you know. But don't be shocked if I have to go virtual on Friday, okay? We've got something we all have to be like in on a virtual meet. It's like a department meeting, but it's going to be virtual, so I don't know where I'm going to be. But we'll see. I'll know better Friday morning. Just figure that out. Number one. Number two, that test tomorrow. So I sent you, it's fairly straightforward. Look, if there's, you guys are fine. I mean, I have to deal with my the first year micro students. But you guys, if there's a headache, just somebody text me, tell me who you are. Since I not only I wouldn't memorize your phones, I don't even know them. Yours I'm gonna block. No, you can't do that. This is you may text me about technical problems. Technical problems. Don't and text wisely. I'll report you. You in particular. What? Oh God. My wife will wonder. I'm going to be with her all day. You know, I could be in big trouble. Who's texting you all that stuff? I could just see it. This could be it. You could cause a distinct schism. Often you get to use the word schism in a sentence. How do you spell? Can you spell schism? I know you can. SCHISM. Ah, I love that. A very Henry VIII. Schism between the development of the Anglican Church, Church of England, and the Catholic Church at that time, all because he wanted to marry another. Love that history. All right, moving on. So you know the deal with regard to that. Just get the darn thing done. It's not that complex, and we'll go from there. So, like I said, just try to make sure you have a strong internet connection. Well, would be, and I'll get on with this. So a few people have contacted me about and we'll be doing the presentations. I suspect Monday I'll have some lecture stuff, and then we'll continue on, and we'll just see how many people are doing presentations on Monday. Maybe we'll just do presentations Monday. So and we'll get through all of this stuff. I'm fairly confident, because I mean, we only have 2 more weeks, and then obviously Science Monday. We're not going to have a class then, because you guys, I can't imagine you want to have anything to do with me then. Moving on. But I'm thinking this is the important part about Science Day. I get to cook. So I'm playing two things. I said I think I'm doing jambalaya. No jambalaya fans? Have you ever had jambalaya? Don't know what you're missing.
I can't. I'm allergic to shrimp, so I can't.
You can't have the shrimp? I can do a non-shrimp. It's pretty hard because you got to use shrimp stock.
I know. That's why I've never had it.
Oh, I didn't know that. You can make it without. Generally, that's part.
I'll trust you that it's good.
Yeah. I mean, look, by the way, if you go there, I always list the ingredients, any allergies and stuff like that. So I usually print the recipes, particularly for stuff like shellfish would be obviously one of them. Because it's it's not it ain't vegan and it ain't vegetarian. Okay, Cajun rarely is. Actually, it's technically Creole. But can you tolerate alcohol? Not you. You have to stop. I'm thinking last year we did a margarita cake. So I think I mean I may do that again, or I may go back to the traditional rum cake. Great. Yeah, everybody's got the recipe. It's a bundt cake. Where's the excitement? Huh? Oh my God, this is to die for. This recipe, it's so good. It is like it's so good.
My wedding cake was funny.
Oh really? Oh, very nice. It's a. I'll go there. Moving on. So on that, this is finishing up the urinary chapter. Now we're getting down to business after nonsense for 5 minutes. And I mean, look, they talk to me. We're just talking about osmolarity. Certainly not going to get into the chemical difference between osmolarity and osmolality. But you see a lot of stuff in the way we evaluate things in osmoles. So, so obviously, and we've all experienced this, if you're overly hydrated, you produce a lot of urine. If you're dehydrated, you produce a very scant amount. That's when our kidneys are working properly. They're adjusting the amount of hydration for what is ever appropriate. Okay, and this is caused by something called the countercurrent mechanism. To frame it for you, this is something I do early on, and we do it a little bit more I do it early on with the MCAT students, and a little bit later with ooh, pardon me. Ooh, aside. We've been burning like we have all these tons of like wood that comes down. We have lots of old trees. Apparently, we're not supposed to have that. We can't like burn that stuff in Cranberry Township. We could have like a fire pit that you could hang out at, but you can't be just burning that stuff. You better not get arrested, dear. She could be in trouble. I know nothing. So we've been busy doing the lawn stuff. So nevertheless, the way that it frames this, it starts in infancy. It's a reason why babies take a certain amount of time to effectively be potty trained, mostly because its mechanism takes basically starts in utero and gradually develops over that in roughly that first 2 to 4 years before this interesting gradient is established. And this is called, and there's two mechanisms. There's what's called the countercurrent multiplier, and in order to keep that multiplier functioning, is something called the countercurrent exchanger. Fair play to all of you. I'm not going to ask a bunch of questions about this on the final. It's a very I have more. It's the most difficult thing I have to explain, and it has always a really good explanation. To be fair, has always eluded me. So I mean, I like to be transparent as much as I can with everybody I teach, not just you because I like you. The few of you that I like. Okay, is no smiling allowed. I shouldn't say that. Nevertheless, I won't. But to try to understand this. So this is the interaction of filtrate flow, and it's all because the hairpin turns. You remember the anatomy. You have those long loops of Henle, and it's a relatively sharp turn. Adjacent to it, you have the vasorecta. And so you have flow going in one direction this way and the other direction that way. So that's what they call the countercurrent mechanism. And because of that mechanism, that sharp turn that it makes, it enables this interesting phenomena to develop based on the anatomy. And again, it takes a while, starting in gestation, continuing to develop at birth when there's a great amount of fluid intake, obviously. And in order to maintain it, you have to have the exchanger. So we're constantly pulling out, and we're pulling out water. And as you might have mentioned with any system, if you pull out water and the solute stays in, it becomes much more concentrated. And then in order to maintain it, we have to pull the solute out at the end of the hairpin. So these hairpin turns are very, very unique in that regard. And they establish and maintain over time what we call the medullary osmotic gradient. And it starts really at the upper area of the loop, which is right at the juncture of the cortex and the medulla. And it runs roughly, and you'll note the exception when we get to the end. It starts more or less at what's 300 milliosmoles, which is approximately our normal osmolarity in the blood. Okay, that's so when we talk about isotonicity having the same solute to solvent concentration in all of our body fluids, this 300 milliosmoles is the approximate amount. And all the way down at the bottom, and what has happened for that to occur, an immense amount of water has been pulled out to concentrate the urine. And we have to offset that eventually with pulling out solute to balance it out so we can continually do it. So the multiplier is what really creates the gradient, and the exchanger, as you will see, preserves the gradient. And a lot of energy is expended, not so much with water. Water comes out basically a process of general osmosis. But in order to pull out the solutes, we expend a lot of energy as active transport. It's surprised how much energy expenditure there is. That's why we do it at rest when we're not expending any other energy. Overnight, we're doing this more than anything else. So most of our energy expenditure is night because all the other systems are sort of at, maintenance mode. Here, this is action mode. And so, and the collecting ducts use this gradient as well, varying the concentration again. When we're using aldosterone, when we're using antidiuretic hormone, that plays a role as well. So here they're kind of showing you what it's like. So the normal osmolarity here in the cortex is about 300, the same as it is within our cell. My voice is going today. And as we reach down farther and farther until we get to finally to the apex, the tip of the pyramid, of these long loops of Henle, we get all the way down to 1200. So the osmolality, and I always get them confused, the internal interstitial fluid increases progressively from 300 at the junction to 1200 at the junction with the pelvis itself. In other words, basically the tip of that pyramid. And you can see it here. And they're pointing out how it gradually increases over time. And these long loops really are the multipliers that are there. So if you keep this picture in mind, this whole osmotic gradient in mind, that's really what's happening here. The vasa recta. Now notice here the arterial blood supply is sort of paralleling, which you see a parallel system in very, very close proximity. Preserve it as we get the exchange process. The water is absorbed back into the circulation. And you can see the energy. I don't know why. Sorry for this. Pardon me, everybody. The energy expenditure is here because you can see we're going from arterial blood to venous blood in these long vasa recta as we're getting the exchange, pulling out the solute to balance out the system. The collecting ducts of the nephrons then use this gradient to adjust the urine as needed. What's there? So there'll be almost like a final adjustment that's made. So the loop depends on filtrate flowing in opposite directions, first down, then up. The difference is in permeability. The descending loop is permeable, very, very permeable to water. That's the thin portion of the loop. The ascending loop is impermeable to water and has to utilize active transport to move solutes in and out in the ascending loop. So the limbs of the nephron loop are not in direct contact, but are close enough to, so to speak, influence each other because of what's being exchanged and the osmolarity or osmolality, whichever one they're talking about here, in the interstitial fluid. So the ascending limb is impermeable to water and selectively permeable to solutes. Sodium chloride are actively resorbed in thick segment, maybe a little bit of passage resorption in the thin segment. The descending limb of the nephron loop is freely permeable to water, but not so to solutes. So water effectively passes out into that hyperosmotic all the way down to 1200, and the remaining filtrate gradually increases till it reaches that 1200. So the surrounding tissue is like that as well. That is the mechanism in a whole. It's interesting in gestation, and not that I'm going to ask you this, but we may touch on it if we have time to do a little bit of review of growth and development, which is not necessarily I'd like to include that in the course if time permits, depending on how much else we have to cover. But it's interesting that rather than removing the water first, we deal more with the solutes. So the start of this process in gestation and at birth and then after birth as it develops is more about, the first step is more about the solutes, and the water is secondary to it. So, and what it does is it maintains a constant difference between the two sides of about 200 milliosmoles between the two limbs of the loop, between the ascending and the descending, with the ascending being less. So the difference is multiplied all the way from the roughly 300 normal down to 1200 at the tip. And you can see it here in a variety of things. And I don't want to go all through all of these, but you can see the water being pulled out in the thin limb, and then the salts being pulled out in the ascending limb in the so-called thick portion. And it just continues. I mean, it's almost like a starting point. They used to have it this way. So here you have this, it's almost as though it starts with pulling out the salt, being able to gradually reduce this hypertonic area by pulling out, the salts within this urine area. The water then leaves by way of the descending limb, the osmolality increases, and we keep doing it over and over again. So that's really the artificial starting point, the salt being pulled out. And so that's originally how it starts, but it's really just a continuous loop that keeps going, more than anything else. So here you can see roughly the difference if we go on a horizontal line here, let's say at 400 on the descending side, 200 on the ascending side. And look what happens as we continue to pull salts out, starting as early as here, fairly deep in the pyramid, toward the apex of the pyramidal structure, all the way up to here. See how hypoosmotic this is. So we're dealing with hypotonic urine, and indeed the urine compared to our normal fluids has a greater proportion of water. It's a hypotonic liquid that's being excreted. So that, here's the filtrate, water moves out. I mean, and again, the starting point, again, if we want to think of it in a pure sense, started here to eventually create this gradient, but in real time, what's happening, we have the resorption of all the important structures, but it enters really as a isotonic media, the filtrate, isotonic liquid. We pull out the water, and then we pull out the salt to balance it out. And we maintain this gradient throughout. It's the best way to express it, I think. And here you can see the very fact when they say pumped out, what does it mean? It means active transport. So the filtrate is at its most dilute state. As it leaves the loop at 100 milliosmoles, it is hypoosmotic to the interstitial fluid. And then it's when it'll leave subtle adjustments. That will be the opportunity to again, whether it's antidiuretic hormone, whether it is aldosterone, being able to pull, whether it's water by itself or sodium, some additional sodium, and pulling out some more water till it meets whatever our needs are. Do we have to release more fluid? Are we a little dehydrated? Do we have to pull fluid in? Whatever the situation is. And again, most of the time varying with the continuous sort of, if you want, sort of the hemostatic basis, the homeostatic basis of maintaining our blood pressure around what is normal for each one of us. So the exchanger maintains it. So the exchanger utilizes the vasa recta. They're very permeable to both these things, water and solutes. So the flow of blood in the vasa recta is also a hairpin turn. So the blood can exchange salts and water with the surrounding interstitial fluid. The countercurrent multiplier is pulling the water first in the down loop and the salts in the upward loop, or the ascending limb, into the interstitial space, and then it's being moved into the vasa recta. And so it's it really in the parallel area. So the blood inside the vasa recta remains isoosmotic with surrounding interstitial fluid. The vasa recta is able to resorb water and solutes without undoing that osmotic gradient effectively created by the counter current multiplier. So the exchanger preserves it, removes the salt, removes and really this is what they're talking about. I think the salt is removed first and then the water is removed second. So water in the ascending vasorecta comes from the descending vasorecta or is reabsorbed from the nephron loop. So either the water's in there to start or it's reabsorbed from the nephron loop or from a collecting duct. So as a result, the volume of blood at the end of the vasorecta is greater than that at the beginning. And you understand what happens. If you think of it, when the blood enters the glomeruli, it loses the vast majority of its fluid. It has enough liquid left in it so it can get through and enter into those vasorecta, which start as tiny arterioles, and by the time they end, they're venules. And literally by that time, they have reabsorbed enough fluid to now have the appropriate amount of fluid, solute, proteins, and formed elements as the blood had that was entering it. And the only thing that's really missing, okay, effectively reclaim 99% of the filtrate, bless you. And we're missing that 1% of stuff we need to excrete, and effectively adjusting the water so we're able to excrete it to the appropriate degree. We have to have enough water so we're not going to have little crystals or little casts in your stuff that could be the framework of kidney stones. Talk about that in just a second. And at the same time, adjust the fluid for whatever our needs are. Oh, I just had a workout. I want to hold on to the fluid. Oh, I just drank a bunch of stuff for whatever reason. Just had a big meal or just a bunch of stuff to drink. And the next thing you know, and now I'm overhydrated. So they're trying to show you where these occur throughout. So once it's established, this osmotic gradient can now be used wherever it's needed to either dilute or concentrate the urine. Without it, we would not be able to raise urine concentration above at 300 milliosmoles, and therefore we would be unable to conserve water. So, I mean, and it's fairly straightforward. Overhydration, excessive fluid intake, large volume, antidiuretic hormone would decrease it. If aldosterone is present, additional ions can be removed. Remember, it pulls out sodium and water along with it, causing the water to dilute to be approximately now down to 50 milliosmoles. So it all depends whether you're in conserve fluid mode or get rid of fluid. So we see all of those things are part of it. You might remember me indicating to you that when we ingest a lot of alcohol, and I know I joke about it all the time, if you drink, it's your call. B, how much you drink, it's your call, depending on the circumstances. But what alcohol does, scientifically speaking, it inhibits the release of antidiuretic hormone. That's why most of us, if we have a couple of drinks, that type of thing, we end up going quite a bit because we don't have the antidiuretic hormone to pull back in the water. And it's almost like the floodgates once it stops here. All those types of things. I never really experienced it because I never was a drinker. I must ask my eldest about this phenomenon. So dehydration produces a very small amount of concentrated urine. So the maximal antidiuretic hormone is released. I mean, theoretically, the urine could be as concentrated as 1,200 milliosmoles. In severe dehydration, we absorb as much of the water as is possible. Okay? And so all of those things, you can see by and large, when we're expelling urine, effectively we're diluting it maximally almost down to 100. That type of thing. And they show you some of these depending on where your activity is, et cetera, et cetera. What helps form this gradient, okay, urea plays an important role. The way again, this is the way the vast majority of the deaminated amino acids that we basically show for our amino acid metabolism that's going on, particularly the catabolic activities, the vast majority of the urea comes from the ammonia from that. It enters the filtrate in the ascending thin limb of the nephron loop by facilitated diffusion. The collecting ducts reabsorb water, leaving the urea behind. Okay? In the deep medullary region, now highly concentrated urea leaves the collecting duct and enters the interstitial fluid of the medulla. And so urea does play a significant role, okay, with regard to that process. So it enters in the filtrate as in the, and it's sort of hard as it begins to ascend. They're still relatively thin. It begins to thicken shortly after that. That's there, and so so it plays an important role with regard to it. Where we have learned a lot about this, and we don't use them as much anymore because of the problems they create. Not so much with somebody having to run to the bathroom, but it's really difficult to control diuretics and how they're used. It used to be the go-to. And the difficulty was it was very difficult to control, particularly potassium levels. So antidiuretic inhibitors such as alcohol, as I was referring to, sodium reabsorption inhibitors such as caffeine, or drugs for hypertension or edema. Okay, so there are different kinds of these diuretics when it's the alcohol just by its very nature. These sodium reabsorption inhibitors, again, caffeine or certain other medications. Loop diuretics really are pretty significant. Okay, and that was really the one that you see the most used in a hospital environment is certainly called, the generic name is furosemide. You may have heard it called Lasix, Lasix. This is used a lot because it works very, very effectively when we have somebody who's fluid overload or their blood pressure is very high, and we're trying to take the strain, particularly off the heart. And you can use that frequently. These patients are catheterized, and we're really it's almost like we're trying to tap out the fluid, if you want to think of it that way. We're trying to force diuresis. Be able to, and in a hospital environment, then you can monitor sodium levels. You can monitor potassium levels and be able to adjust those by intravenous, by using like intravenous potassium. It's kind of like how it was going on with me. When I was in intensive care, my potassium levels had lowered so much that they were critically low and they had to put potassium in, yet effectively my kidneys had shut down. So I had to be catheterized for a couple of days. When I was sitting there in intensive care, I didn't care. I was so freaking sick. Do whatever you want, just get me through. My wish for all of you is never to be that sick. That is not a good place to be. So these are used a lot. I mean, this is the thing. This is what glucose does. Effectively, it's an osmotic diuretic. Remember, diabetes, the great thirst. It's the sugar. When you go over that transport maximum, you're spilling, and that's the terminology we use, glucose into the urine. It pulls water along for the party. So water remains in the urine. For example, in a diabetic with high glucose concentration, the water goes along to basically keep the urine dilute enough so it will pass. And so this is the whole idea. It's a very easy way to be able to determine abnormalities without having to do something invasive. So for instance, it's for you and I, if you go into an emergency room, an urgent care, and they go, gee, can you give me some urine so we can do it? And they can do a dipstick test or take a quick look under a microscope. You can get a lot of information. This is the first test that they do before you have to start sticking needles into people, particularly infants. So at Children's Hospital, when a child comes in with what's called an FUO, which is a fever of unknown origin, the first test they do before they try to stick a needle in this poor in an infant or a little kid, they do a urinalysis. The urinalysis, particularly when you're dealing with, with infant, with still in babies, and they can't explain to you where it hurts, and they're panic stricken, and all that type of stuff. The urinalysis gives you a lot of information right away. Is it an active infection? Is it a urinary tract infection? What's causing this fever? By that time, I may have told you this before, by that time, if you haven't got enough information, they still aren't going to stick a needle in that baby. They do a chest x-ray because maybe it's pneumonia. And again, it's hard to, when the baby's screaming, it's pretty hard to hear breath sounds. If that doesn't tell you, the next test, believe it or not, children, is you're going to do a lumbar puncture. By that time, we better figure out if this is bacterial meningitis, because if it is, we have to know right now. That's the first real invasive test they do. That was the protocol forever at Children's Hospital. Maybe it's changed, maybe it hasn't. That's what happens to my eldest. Now, oh God, he's so old. Now middle-aged at 43, when he contracted rotavirus, and we were in San Antonio, at the Santa Rosa Children's Medical Center in San Antonio, a giant hospital, and he got rotavirus. They did not know. So when we brought him in there, they had to do that. They had to do that spinal tap and find out right away. Okay, it's negative. This is probably rotavirus versus being meningitis. We were 2,000 miles away from home. The moral of the story is, don't take your kid into an area where rotavirus is endemic, and people have basically have herd immunity to that virus, and we ended up with a critically ill child. This has spoiled a very nice vacation. It's a very interesting saga. So for those who are parents or are going to become parents, whenever you take your kid when they're little away, find out what's going on. Don't go to an exotic area compared to where you live. So we took our kid 2,000 miles away to celebrate New Year's with another couple who we were very, very close with, we were all part of the same adoption agency process. Moving on. So, blood and urine is the examination. So typically in adults, we look at nitrogenous waste. Those nitrogenous wastes, as I said before, are BUNs, which stands for blood urea nitrogen, and creatinine. Those numbers start to go up. Your kidney function is no longer functioning where it's supposed to be. Mine were 10 times normal. So when they admitted me, I can remember obviously something like that, my memory is good, as you know. I can remember that an ER doc going to me, well, we'd like to admit you. And then right after they kind of looked to intensive care. Ah! I was so sick, I didn't care what they did. So you have to, and now we need both blood and urine to be able to establish these things. So the volume of plasma as the kidneys clear, this is all about your glomerular filtration rate. We estimate it now with blood tests. We dipstick the urine to see if there's some obvious answer. I'll comment on that in a second. So all of those are really important. In people with long-term kidney disease, and again, it's mostly diabetics, sometimes folks with lupus, those are the two big areas. They have to basically to assess or calculate the renal clearance without going into all the numbers. This is the way it was traditionally done with 24-hour urines. So this is a polysaccharide that's been used and may still be used. It's freely filtered. In other words, it's easy to get its way into the filtrate, but it's neither resorbed nor secreted. And so its clearance is how we use to standardize the GFR of 125 millimeters per minute. We estimate it with those blood tests. So if it's cleared less, it's being reabsorbed. If it's cleared 0, the substance was completely reabsorbed and not filtered. So the clearance, if there's no net reabsorption or secretion, is 125 milliliters per minute. So we have to find out all of those types of things that are there. And that's when we begin to speak in terms like that, any of you going into these fields will look at the glomerular filtration rate. It's supposed to be just about 125 milliliters per minute. If for some reason it falls below 60, and this is one of the estimates that you can estimate from those blood tests, at this point for 3 months or more, it is very significant. And the implication is chronic renal disease. It means your kidneys are under such a degree of stress and are not functioning sufficiently that they're likely heading toward failure. Okay, filtrate formation decreases, nitrogenous waste accumulate. Typically, the blood is more acidic, and we see this in both diabetes and in chronic high blood pressure. If it is below 15 milliliters per minute, at that point, we're at renal failure. And what we see, really the first sign is uremia. What means the urea is now accumulating. That blood urea nitrogen level is so high that is going to lead to a variety of disturbances that are there. It's inherently toxic. Interestingly, I recall this because of my grandfather whose kidneys failed. He had lost a kidney because of an antibiotic they were using back in the early days. So he only had one kidney that functioned. When I say lost, it wasn't removed. It was no longer functional. And the first sign, interestingly enough, itching. Like that. And then it manifests itself differently. So all of these, it could be fatigue, it could be loss of appetite, it could be nausea. It was very interesting because we started to see, I would hesitate to call mental changes as much as behavioral changes. It's very interesting now that I reflect back. I was in med school at the time. He died in 1976, as I recall. And it was interesting. He lived to 86 years old, but it was very interesting to see the behavioral changes that were going on. And the thing was, he was not a candidate for a kidney transplant. He really wasn't a candidate for dialysis the way they had it at that point in time. So I mean, we're talking about 50 years ago. Things have changed. So they were unable to do either of those things, two things, and eventually he succumbed to that. So if we look at urine itself, the vast majority of it's water, a certain amount of solutes, urea, uric acid, creatinine are all part of this. The largest component is certainly urea. There's other things that we see. So abnormally high concentrations of any of these or anything is abnormal. So when we dipstick the urine, if you see proteins, if you see white blood cells, if you see abnormal chemicals in there, that's a quick look into something's going on. That would be there. So if we see glucose, diabetes. If we see proteins, it could be something non-pathological, physical exertion, pregnancy. When we start to see pathological levels, you're starting to think of, is there something going on in the glomeruli? Are we dealing with something with long-term hypertension, heart failure, some type of renal disease? Because it should not be there. It's there. Ketone bodies. Again, classically, diabetes that's not managed. Sure.
Is this the only food that you can dipstick to get these?
Pardon me?
But is this the only bodily food that you can dipstick to get these substances?
I didn't hear the first part of the question right.
Is this the only body food that you can dipstick?
No, not necessarily. I think I short answer, don't know. I would think so. I mean, I don't doubt that we could dipstick saliva and get some information. But classically, it was urine that was there because we didn't have the luxury of glucometers where you could do finger sticks and things like that fairly easily. And even some techniques now where you don't have to stick yourself to be able to at least see glucose levels. But I really think that's the only one that we classically do dipstick. Unless someone's aware of some others. I mean, I can look that up and see. I don't think so. For instance, if you're looking for, like when they did, I go over this when we start talking about the next topic, which is repro physiology. We were an infertile couple. And so they inevitably, they look at semen. They need a semen sample to see if there's an adequate amount and there's adequate motility. You don't do that. You're assessing that in a laboratory sense. They're doing the count in a laboratory and they're looking at it microscopically. Oh, good Lord. My poor daughter. She's checking it. Hold on. We're supposed to have a conversation. So the short answer is I don't know for sure, but I think this is the only one. So this is the kind of things, if we see ketones in the urine, it's desirable if you're on a keto diet, you want to have that. Okay, that's part of the goal. To be able to impact you effectively to affect ketosis. You don't want to see hemoglobin. You don't want to see bile pigments. You don't want to see red cells, or you certainly don't want to see white cells. All of those are significant. If it's cloudy, typically that implication is white blood cells. We look for the pigment, okay? So we should see that, and again, if it's overly concentrated or under concentrated. So you might notice it yourself. After urinating, after being physically very active, it tends to have an increased degree of pigmentation. Certainly, there are foods that can do it. There are medications that can do it. Okay, all of those types of things. So when we see a color that you can't normally explain, you have to start thinking what would be the underlying reason for this to occur. Uh, Over time, it's like in the old days before we had disposable diapers, they had diaper pails, and they had a pretty distinctive odor of ammonia because you had a diaper service. And some people, I don't know if they still use those things or not. They'd have a diaper service that would take the typical cotton or the cloth diapers and launder them and return them to you. Some people are not into it all, using disposable diapers. And there are certain things that have a very distinctive odor. Certain medications, the one I can think of from a food perspective is asparagus. And again, diabetics more so with that. So it's slightly acidic. Certain diets can impact it. Certainly, if you, I don't know that. I mean, I know with vegetarians it's different. Certainly, anything with vomiting or urinary tract infections. Specific gravity is something that's dipsticked. That's part of the test. So if it's outside the normal range, it basically implies there's an abnormal amount of solutes that are there. So I mean, the only reason I have a lot of familiarity because of my bladder cancer. I mean, I had to give them a specimen whenever I walked in. I mean, it was good. Oh, Lou, your urine looks good. Oh, thank you. Can I look at yours? I had a very flip attitude. I had a very interesting relationship with my urologist, who, by the way, and if you're interested, I don't know if anybody is interested in shadowing in that area. I'm not shy about asking him if anybody was interested in going to urology. He runs the residency down at AGH. So he's brilliant. He was the lead. Remember that Jameson Tayon, who's now pitching for the Cubs? He was a Pirate, and he ended up with testicular cancer that had to be treated. I mean, he's the one who operated on it. I give him a hard time because he goes, "I'm so glad you're here. I love to do surgery. Maybe there's something we can do." Now I come in and go, "I am not humoring you anymore. You're not going to operate unless there's absolutely a need." We have that kind of interchange. Are you still teaching? Are you still operating? You and I have that unusual. And there's really not a lot to say. This is the only reason I'm having it as we conclude today. It's about kidney stones. And a lot of times, this is one of the things you're looking for. If there's blood, if there's excessive calcium, if there's bacteria, all of these can be what we call a nidus, a core for potentially kidney stones. And they used to think it was typically men. We're seeing a lot more women with it. Okay, most of the time they're not a problem. Thankfully, we have lithotripsy, just like with gallstones. You can bombard these areas with high frequency ultrasound powerfully and destroy these. It's been a real. It's not necessarily it's a process where they have to people undergo this. You have to sedate them. They're typically in water, like in a special, almost like a special whirlpool kind of a bath without the whirlpool. So they have to be in a bath, a water type environment. And so, I mean, there's not a whole lot. This is all anatomy that's there. The reason this is the transitional epithelium that you recall. That's what I had. My bladder cancer was from. Thankfully, mine was very superficial. So it was within the transitional epithelia. It had not gone deeper. It was just at the process of going deeper into the underlying tissue. So it was called a TEP1, transitional epithelial 1 type cancer, which could be treated with a variety of means. Fortunately, they were doing immunotherapy that had to stop because it had caused an immunological reaction, and they never had to use the chemotherapy, even though that was available at the time. I don't think there's a whole lot out. UTIs, I think we'll look at this a little bit more. They're certainly more prone in women than in men. We'll look at it with regard to sexual act. We'll talk about more of this when we look more at the female reproductive aspects of things that are there. And I really think that's everything. So we'll conclude here, and we'll do in lecture male reprophysiology, which is easy, and then female reproduction, female reprophysiology, which is more complex. Thanks, guys. We'll see you. I'll let you know Monday. Let me let you know rather on Friday what's going on.